start when you're ready.
Okay. So my name is Mark Forsyth and my number is 2129569 and I'm level 7. Okay. Hello, my name is Mark. I'm from STARS. I'm here to do an OSCE exam today. Is it okay if I examine you?
Yeah.
If anything is painful or uncomfortable or you don't wish to carry on, just let me know at any time.
Yeah.
Okay. As I'm coming in, I would be doing my risk assessment, checking level of consciousness, ABCs. I can see that he's GCS 15 and his airway is clear, his breathing and circulation seems like it's working as he's up talking to me. I'm now going to wash my hands, and then I'll be checking all the vital signs, so temperature, pulse, respiration, oxygen saturation, blood pressure in line and standing. I'll do this BMI calculation and waist circumference. Okay, I'm now going to ask you a few questions to assess his mental status. Can you tell me your remember this address, 42 West Street. I'm going to ask you that back shortly, okay?
Yeah.
Where did you go on holiday last year?
Isle of Wight.
Okay, and the year before that?
India.
Okay. Can you tell me your name?
Jisho.
Okay, can you tell me what day it is?
Today is 4th of August 2015.
Okay. And the day?
Tuesday.
Okay. Do you know where you are?
Yeah, University of West London.
Okay, great. And I want you to tell me, I'm going to ask you a few questions. Can you tell me what an apple and an orange have in common?
Both are fruits.
Okay. Can you draw a square inside the circle? Can I do that? All right. So just draw the shape of a square and a circle for me. Okay, lovely. Thank you. And I did that appropriately. Can you add 4 plus 5 minus 2?
7.
Okay, thank you very much. Can you tell me the capital of England?
London.
Okay, what was that address I asked you?
42 West Street.
Okay, that's great. So I'm now going to move on to my cranial nerves. I'm going to do my cranial nerves first, okay? I'm going to start with olfactory. So I'm going to ask you just to put a finger over one nostril and then smell this with the other one, if you can do that now. Take a smell.
Vinegar.
Yeah, that's vinegar. Okay, so I'm now going to do the optic nerve, so look at visual acuity. Just hold that out at arm's length and try the third bottom line for me.
Yeah, 3, 7.
Sorry, hang on a second. Do you wear glasses?
No, I don't.
Okay, yeah, cover one eye for me. Okay, and now try.
374258 EWEXX0.
Great, can you do the next line?
937826
And the last one?
428739.
Okay, that's great, excellent. And I would be assessing both sides. Okay, so I would then also assess the colour discrimination, but I don't have a colour chart at the moment. I'm going to look at his peripheral vision, so just look at my nose. Okay, can you see what my hands are doing?
Yeah.
What they're doing?
Shaking.
Okay, that's fine. I'm going to check his pupil's response. Okay, just look at my nose, eyes nice and wide for me. Okay, and again. Okay, so pupils equal and reactive bilaterally, both sides reacting when I put shiny light in the alternate eye, and it's going from about 3 to 2 millimeters. Okay, I'm now going to look at the ocular motor, trochlear and abducens nerves, so I'm looking at eye movement. So just look at my finger, okay, and follow it, don't move your head. Don't move your head. I'm looking at convergence there, and that all seems to be working fine. I'm now going to look at the trigeminal nerve. So I've got soft. Can I use these ones or use these ones?
They're both needed.
Alright. Okay, I'm just going to place this on your hand. That's soft and that's sharp, okay?
Okay. That's really sharp.
Alright, so I'm going to start in the ophthalmic region. Softer, sharp.
Soft.
Softer, sharp.
Sharp.
Okay, and then we'd also do the maxilla and mandibular regions in both sides. So that's assessed for the sensation there. And I'd also use a cotton wool and check for the corneal reflex, which I'm not going to do just now. From the motor side of things, I'm going to check muscles of mastication. I'll feel the temporomandibular joint. Okay, can you open and close your mouth? That's great. So muscles of mastication are working fine. And then I'm going to look at the facial nerves. So can you smile for me? Frown. Puff your cheeks out. Very good. And show your teeth for me. Grit your teeth. Excellent. And now I'm going to assess taste. Okay, just take one of those and tell me if it's sweet or sour.
Sweet.
Okay, very good. I'm now going to do the acoustic nerve. So I'll let you finish that.
Yeah.
Okay. I've just also checked his swallow there, which is going to come to later, but anyway, done that as well. Okay, just tell me what you can hear.
1, 2, 3.
Okay, great. And I would do the same on the other side. Okay, and now we're going to do a Weber's test. Just tell me if you can hear both sides.
Yeah.
So that's for lateralization. And now we're going to do a Rennie's test. I'd only do that if there was a problem there. So I'm first going to place it on the mastoid bone. Tell me when you can't hear it anymore.
Yeah.
Can you still hear?
Yeah.
Okay, very good. So that's working. The conduction across the ear is working better than the crossbone, which is what we'd expect. So glossopharyngeal is the gag reflex. I'm not going to assess that at the moment. The vagus nerve, I've already assessed the swallow, and he's talking, so that's also assessed. Can you just open your mouth for me? I'd use it and say ah.
Ah.
Okay, and the uvula, let me just use that light. Do that again for me. Say ah.
Ah.
Okay, so uvula is central and the palate turns off seems bilateral. So that's vagus nerve. Spinal accessory nerve, can you shrug your shoulders for me? Okay, so it's testing the upper trapezius muscle. And then turn your head to the left against my hand. Good. And the other way. Good. So that's sternocleidomastoid, so that's spinal accessory. And now do a hypoglossal, stick your tongue out for me. And put side to side. Okay, so that's all cranial nerves tested and they all are intact. I'm now going to go on to the head-to-toe examination proper. I start with skin, looking at the skin, looking for the colour, if there's any sweating, any obvious rashes, and I'll be feeling for temperature, but I'm going to cover that as I do each system. So starting with the head looks round, it's symmetrical, there's no obvious lesions or rashes, no signs of trauma. So I'm now going to palpate around the head and just tell me if there's any pain as I'm palpating. So I'm feeling for signs of tenderness or any hematomas or bumps, and that all feels normal. I'm now going to look at the eyes, so I'm looking at the external structures of the eyes, and again there's no trauma, no discharge, just sclera and conjunctiva look clear. Just look up for me, just going to pull down your lower eyelid. Okay, and extend the other side. Okay, nice red capillary bed there, so there's no evidence of anemia looking at the eyes. I'm now just going to look at the back of the eye. I'm going to get my fundoscope out. So I'm just going to shine, well, that's set to 0, I've got light there. I'm just going to shine a bright eye at your light, in your eye, sorry. So I'm going to use right hand for right eye, so that I don't, can you just look at that top of the curtain rail for me?
Yeah.
And just keep staring forward. So I'm looking for the red reflex. Okay. I'm looking at fundus. Okay, great. Okay. So I can see the fundus, I can see the red dot, and there's no sign of hemorrhage. Okay. You alright?
Yeah.
Okay, so I'm now going to look at the ears, so I'm looking at the auricles and tragus, both ears, and making sure there's no discharge, blood or cerebral spinal fluid, everything looks normal there, no discharge. I'm going to use an otoscope a minute to look down the auditory canal, but whilst I'm here I'm just going to press on the tragus, and if there was any tenderness that might suggest that there might be inflammation in the canal. So I'm now going to get my otoscope out. Okay. So just going to pull on the auricle. Okay, great. And I can see down the canal there's no sign of inflammation, and I can see the tympanic membrane, and that's intact. Okay, so now I'm going to move on to the nose, and the external structures of the nose are intact. The nasal septum is also intact, and the nares, external nares, are clear. Can you just cover your finger over one there? Okay, and breathe through it. Okay, and do the same other one. Okay, so I've just assessed the patency and they're both intact. I'm just going to have a feel of the sinuses. Just let me know if there's any pain or tenderness. I'll do that with percussion as well. And there's no tenderness there. Okay, I'm now going to inspect the mouth and the lips. So the lips look, there's no sign of cyanosis, there's no cracking or bleeding. Can you open your mouth for me? I'm just going to inspect the inside of the mouth, looking at the gingiva and the soft palate. Try and stick your tongue out for me. Okay. Looking at the back of the mouth, looking at the tonsils and uvula, and then just stick your tongue out to the side. Normally I'd use a tongue depressor to make this easier, but I'm not going to do that today for the exam. Okay, just stick your tongue to the side. Okay, and lift your tongue up. Okay, great. So I can look at the salivary glands, and I'd also be getting a glove and feeling that with my gloves. So the palpations for the salivary glands, I'm saying, are normal in this case. That completes the mouth. So I'm now going to move on to the neck and lymphatic system. I'm going to do together. So I'm inspecting the neck for any signs of goiter, inspecting the thyroid, and there's no obvious signs of goiter. I'd also inspect the impetus rising on swallow. I've already done swallow, and I can see that the impetus was rising. And I've already said about inspecting and palpating the salivary glands, so I'll move on to my cervical chain. So I'm going to palpate the thyroid. Okay, great, that doesn't feel enlarged. I'm going to move on to the occipital node, round to the post-auricular, pre-auricular, superficial cervical, deep cervical, tonsillar, submandibular, supraclavicular, and none of them are enlarged. I would also do the axillary, breast and groin, but I'm not going to do that for the exam. Now I'm going to ask you to move your head in 6 different ranges. So if you can turn your head over your right shoulder, that's great, and back the other way over your left shoulder. Okay, back to the middle, and then bring your head down towards your chest. Great, and back to the middle, up to the ceiling. Good, and back to the middle, and then right ear to right shoulder, side bending. Great, and the other direction. Okay, great, and back to the middle. So he's got normal range of motion of his neck. I've already done my resistant movements during my cranial nerves. I'm just going to palpate the neck to make sure the trachea is central, which I would have noticed if there was any deviation in my primary survey, but that feels central. I'm just going to feel the cervical spine from C2 to C5. Let me know if there's any pain or tenderness. And that all feels central, and there's no obvious signs of pain whilst I'm palpating. So that completes my lymphatic system, and also I've done my first musculoskeletal joint, so that's my neck. So I'm now going to move on to the thorax chest system. Are you okay to take off your shirt for me?
Yeah. And this one?
If you're happy to.
Yeah.
Okay. So under general inspection of the chest thorax area, looking at respiratory rate and rhythm, and any obvious signs of increased work of breathing, respiratory distress should be evident in this position. Also, if there's any signs of central cyanosis, as we've already mentioned before, I'm also going to look at his hands. If you can stick your hands up like that for me. Okay, good. And then back down there. So there's no flap, which should be a sign of CO2 retention, and there's no tremor, which should be a sign of overuse of beta agonist salbutamol. I can't see any signs of clubbing, which would be a sign of chronic hypoxia, and there's no nicotine staining, so he doesn't appear to be a heavy smoker. I'm looking at his inspiration to expiration ratio, and that seems to be normal 1 to 2. I'm going to walk round looking at the AP diameter, and again that's a normal ratio, so the lateral side is smaller than the anterior view. I'm going to come round to the posterior aspect to do a posterior assessment of the chest. So looking at his chest, it seems to be symmetrical. There's no obvious lesions, no signs of trauma or surgery. There's no rashes. His breathing looks relaxed. His work of breathing is low. So I'll now go on to palpation. I'm just going to touch your back all over, okay? So let me know if there's any pain or discomfort for you. There's no obvious deformities or abnormalities, and he's not demonstrating any signs of tenderness. Okay, I'm now going to have a look at his expansion. So I feel bottom of the 12th rib, feel round, up a couple for T10. Okay, and then just take a nice deep breath in for me. Good, and out. Okay, good. And his expansion is bilateral and equal. I'm now going to do tactile fremitus. Okay, so can you put your hands across your chest for me? Okay. So now just say 99 for me.
99.
And again?
99.
And again?
99.
Okay, so the vibrations are equal throughout. If they were increased, decreased or absent in one of the areas, then that would suggest possible consolidation or something that warrants further investigation for. I'm now going to go on to percussion. So I don't know if you can see this, but I'm going to start up here and I move across. So I'm using ladder fashion, doing 5 centrally bilaterally, and then 2 peripherally, also bilaterally. Okay, and that sounds resonant throughout, and there's no hyporesonance or hyperresonance. Obviously, if it's hyperresonant, it suggests that there's more air, and I'd be worried potentially about pneumothorax. Hyporesonant or dull would suggest possibly some fluid, like an effusion, but everything seems like it's resonant throughout with no changes. I'm now going to look at his diaphragmatic excursion. So in this position, can you just take a deep breath in and then breathe out? Okay. Just hold your breath. Okay. Right, that's there. Just going to mark your back there, okay?
Yeah.
Okay, and then we're going to do that again. Okay, so this time I want you to do the same thing, but then hold the breath. So take a deep breath and then breathe in and hold it. Hold, good. Okay, just breathe out for me. Okay, so I'm going to do that again because I didn't hear it. Okay, nice big deep breath in, hold it again. Okay, good. Okay, there. Okay, so that's looking at the difference from where the diaphragm is in expiration, inspiration should be 3 to 5 centimeters, and here it looks about 4 centimeters, so that seems normal. I'd also do the same on the opposite side. But now I'm going to move on to auscultation. Okay. Okay, so I'm now going to auscultate along the same fadder fashion that I percussed. Okay, so take a breath in for me, and out, and again. Good. And then I would continue down the same pattern as I've just done for the percussion that I explained already. Okay. If I hear any added sounds anywhere where I'm considering there may be some percussion, then I would then think about doing some special tests, voice transmitted sounds. So I would then place the stethoscope over all the same areas, but particularly where I heard the added sounds, and then ask him to perform these tests. So the first one is bronchophony. I'll pretend my ears are listening, but essentially I want you to say 99 for me, sir.
99.
And again?
99.
Okay, and I will continue. So if the 99 was louder and clearer in the area that I was considering there was consolidation, then that would be a positive finding. I'm now going to do whispered pectriloquy. So same again, listening over all the areas. Okay, and then this time I just want you to whisper 1, 2, 3.
1, 2, 3. 1, 2, 3.
Okay, great. And again, over the area that I'm concerned about, I would expect it to be hearing louder and clearer, as that would be positive for consolidation in that area. And the last one would be the egophony. Okay, so same again, and this time I want you to say E.
E.
And again?
E.
Okay, and this time I'd expect it to come out at A, and that would be positive for that. Okay, that completes my assessment of the posterior thorax. I'm going to move round to the front, or the anterior chest, I should say. Okay, just put your arms down on your lap for me. So I'm inspecting the chest, which I've already done a general survey, but I'm just looking a bit more closely. Any use of the accessory muscles, particularly in the lower aspect of the chest, would be evident of somebody in severe respiratory distress. And I'm looking for, again, any surgical scars or trauma, any bruising, any flail segments would be obvious. From there I'll go on to palpation. So feeling down the sternum and the ribs, and again any tenderness, the patient will give me a sign, and I'm feeling for any irregularities or deformities. And then going to move on to percussion, and again the ladder system, but this time I'm only going to do 4 essentially, and then 2 bilaterally. And then I move on to auscultation, and I auscultate over the exact same areas, and again if I find any added sounds of areas of interest, then again I could do my voice transmitted test, but otherwise that completes my assessment of the thorax. I'm now going to move on to my assessment of the chest. So I'm going to start of the heart, the heart and cardiovascular system. I start with inspection of peripheral vascular system. So I'm going to look at the eyes again. I've already looked at the eyes, but I'm particularly thinking about signs of xanthelasma, which could be an indication of high lipids, high cholesterol. I'm looking for corneal arcus, which could be a sign of ischemic heart disease. I'm going to look at the eyelids. I've already done if there's any signs of anemia, which there's not. I'm going to have a look at your hands. Can I have a look at your hands again? I've already done this in the respiratory, but specifically I'm thinking about splinter hemorrhages. Could be a sign of endocarditis, or clubbing, sign of hypoxia, and there's none of that evident. Also, I'd be looking for any malar flush in the face, and that could be a sign of a mitral valve abnormality. I'm also going to look at the feet for any signs of peripheral edema, be a sign of heart failure. Are you alright to take your shoes and socks off for me, sir?
Yeah.
Do you mind taking both off? Could have one-sided swelling, so you need to check both. Okay, so anyway, I'm looking at the feet and the ankles, and I'm skipping on to palpation, seeing as I'm down by the feet, and there's no signs of peripheral edema, pitting edema, anything like that. If there's none here, I wouldn't expect any further up, but I will be looking at a sacrum later. Alright, sir, if you don't mind just having a lie down for me. Okay. Just put your arms down to the side if you don't mind. Okay, so I'm just inspecting the precordial area, looking for any signs of heaves, and there doesn't appear to be any. And I'm now going to look at the jugular venous pressure. Inspect the jugular venous pressure. We don't have a ruler, so we're just estimating. Okay, sir. If you just...
So the ruler is on the other side.
Oh, okay. Where's the ruler?
There's a time depressor there if you want it, yeah.
Alright, so I'll make sure the bed is at 30 degrees, which there's no indication on this bed, but I would suggest it's not too far off 30 degrees. I'm just going to put it up slightly. That looks about 30 degrees to me. Just turn your head 45 degrees to the left. Okay, I'm now looking for the jugular vein. Oh yeah, and I can see pulse coming down the way there, highlighted by the light. Okay, so I'm going to feel for the sternal angle, put my tongue depressor there, and where I can see, I'm doing that the wrong way around, where I can see the start of the jugular vein pulse and go across. Okay. Looks about 2 centimeters to me. Like normal would be 55, so we can say at least that there is not an increased jugular venous pressure. Okay. So I'm in inspection. I'm now going to move on to palpation. You can move your head back, sir. Okay. So I'm going to palpate. So I'll come back around this thing. I'm going to palpate for the pulses. So I'll start with the carotid pulse. Okay, just turn your head slightly to the side. I just feel one at a time. Alright, he's got a strong carotid pulse. Okay, that's great. And there's no thrills. If there was any, then I'd consider auscultation with bruit, but that doesn't seem to be necessary. I'd also do the other side, so make sure you do one at a time. I'm also going to palpate for a radial pulse bilaterally. Make sure I'm feeling for the rate, rhythm and pulse pressure, and they're equal and regular with a good pulse pressure. Okay. I'm also going to check, and I'll do all these bilaterally, brachial pulse, femoral, popliteal, which we'll do in this position, dorsalis pedis, and posterior tibialis pulse. I'm now going to do palpation of the precordial area. So I'm going to palpate the left parasternal region. Again, feeling for any thrills, and there's none. And I'm feeling for the point of maximal impulse. It should be in mid-clavicular line just below the nipple. Yep, and I can feel that there, which would suggest he's got a normal anatomy. Okay, I'm now going to move on to auscultation. So I'm going to auscultate the precordial area. As I said, if there was any thrills felt, I'd be auscultating those areas, but
particularly carotid artery, but there's none, so I'm going to move on to my landmarks of the heart. So first of all, I'll do the aortic area, so I'll be doing the right parasternal region, the second intercostal space. So I'll feel down the second intercostal space, and I'm going to do this with the diaphragm to start with. Okay, good. And I'm going to do the right parasternal border, second intercostal space for pulmonic region. Good. Okay, tricuspid, right parasternal, fourth intercostal space. Okay, and mitral valve, I'm going to go midclavicular, fifth intercostal space. Okay, and I can hear S1 and S2 in all areas. I'll then move to the bell for the apex. Okay, can't hear too well. Do you mind moving on to your left side slightly, sir? Okay, do a bit more for me? Okay. So now listening for mitral valve abnormalities. Okay, that's great, and I can't hear any added sounds. Another way I could do that is to get him to sit up, which I'm going to get you to do now if you don't mind sitting up, sir. So I could again listen to the apex there for any abnormalities. I'll move it back to the diaphragm. I'm just going to listen to the bases of the lungs, which I've already done in my respiratory assessment. Okay. Take a deep breath for me. Good. And again. Okay. Again. And again. Okay, great. And there's no added sign, no sign of pulmonary edema. And then also looking at the sacrum to see if there's any sacral edema, and there appears to be none. Okay, so you can lie back down. That completes my cardiorespiratory assessment. Sorry, cardiovascular assessment. I've already done my respiratory assessment. I'm now going to move on to my abdominal assessment. You put your hands down by this side, thank you. Okay, so I'm inspecting the abdomen. I'm looking at the shape, if it's symmetrical. I'm looking for any rashes, spider ascites, trauma, surgery, and I can't find any of those things. So my inspection is fairly unremarkable. I'm going to now go on to auscultation. Normally I would do palpation, but for the abdominal I don't want to interfere with any of my percussion could affect the sounds I'll hear in auscultation, so I'll do auscultation first. I'm going to come around to that side again. So I'm going to start with diaphragm. I'm going to go around 4 quadrants for the high pitch sounds, and I'll use the bell for the low pitch sounds. So I'm listening for bowel sounds. Okay, good. So I can hear bowel sounds. So listen for about 15 seconds, and I go around each quadrant. Okay, and then do the same with the bell, 15 seconds each quadrant. I'm then going to listen for any possible bruit. So for with the bell, aortic, renal, iliac, and femoral. I'll just listen to the aorta just now. Okay, and there's no signs of any bruit. That completes my auscultation. I'm then going to go on to palpation. So I'm going to palpate superficially at first, again in all 4 quadrants. Okay, I'm looking for any signs of guarding, which doesn't appear to be any. Any abnormalities of swelling, and I'm going to go deeper, 5 to 8 centimeters. And again, looking for the same things, any guarding or any unusual swellings, nodes, feeling for any guinal or femoral nodes, but I can't feel any. I'm also feeling for the borders of the liver and the spleen. Also going to feel for enlarged kidney, and I can't feel any of those organs enlarged. However, I'm going to use percussion to see if I can find the areas of the liver and the spleen. So I'm going to work down the midclavicular line from top to bottom. Okay, it's definitely there. Let me try that again. So different there. Okay, I'll try again from the top. Okay, different there. So I've got an area here which I would measure. I'd expect the liver to be between 7 and 12 centimetres. That looks like it's towards a smaller range. I'll do the same for the spleen and liver side, which I would consider to be around 6 centimetres. And I just have one last thing to do with percussion. So if you don't mind sitting up for me, sir, I'm just going to have a look at your kidneys. Just sit with your legs over the edge of the bed, if that's okay. So I'm going to do my CVAT, find the costovertebral angle. Okay, and you're going to feel a small percussion, okay? Don't just tell me if that's painful. That's fine. Okay, and then if you just lie back down for me, sir. I go on to my special test. Okay, I'm just going to feel under your ribs. Okay, take a deep breath in for me and out. Does that cause you any pain?
No.
Okay, so that's Murphy's sign, looking for signs of colic cystitis. If it was uncomfortable, that would be positive. I'm now going to do a rebound test. So I'm just going to press into your left iliac fossa, this area here. Okay, and if that was tender, if there's any guarding, that would also be positive, and that would be a sign of possible peritoneum inflammation or appendicitis. The appendix is over there, but that's how you would test for it. And last, I'll do my fluid tap test. So if you can just put your hands like that, sir. Okay, I'm just gonna. Okay, great. So if that movement that's seen in this side of the abdomen transferred across the midline, then that would be positive. You'd expect that there's some fluid in the abdomen there. And that completes my abdominal assessment. Okay. And now I'm going to move on to my second musculoskeletal joint, which I'm choosing to do the knee. I'm just going to put the bed up slightly for this. Are you able to roll your trouser leg up, sir?
Yeah.
So again, I'll be doing, for the purpose of the osteo, I'll just be doing one knee, but I would always do bilaterally, as I did with the ears and the eyes. Okay, I haven't got a good view of the knee. I prefer that I could see from this point down at least. But I'm looking at the knee, inspecting the knee for any signs of swelling or deformity. Again, any signs of trauma, any inflammation, redness, any lesions, and there's no signs of anything like that. It seems equal when compared with the other knee. I'm going to go on to palpation, so I'm going to palpate quadriceps down. I'm going to palpate over the patella, head fibula, and down the patella tendon. Okay, that all feels intact. There's no signs of tenderness. If there was pain over the patella, the head fibula, and the patient was unable to weight bear, then the autoimmune was positive, and I'd be considering an X-ray. I'm now going to have a look at his movement. Can you bend this knee for me, sir? So I'm looking at flexion. Bend it as far as you can. Good. And extend it. So straighten your leg. That's great. So there's normal range of motion there. I just want you to lift your leg up straight. Okay, and there's excellent relax. There's good extension mechanism there. I'm now going to move the leg passively for him. Okay, and there's normal range of motion of the knee passively as well, and there's no block in the joint when I hyperextend his knee. I'm now going to check his muscle strength. Okay, so I'm just going to lift your leg up. Okay, so just straighten your leg against my hand. Good, and then bring it the other way. Good. So he's got good muscle power and 5 out of 5 for both flexion and extension. I'm going to move on to my special tests of the knee. So I'm going to start with lateral medial stress test for the lateral medial ligaments. There's no laxity there, but you'd only be certain really with comparing it to the other side. Okay, and then move on to the cruciate ligament. Sorry, I'm going to have to sit on your foot here. So this is anterior drawer test. Feeling for laxity, and again I need to check that with the other side. And then I'll now check for the meniscus. I'm searching for any signs of crepitus, pain, discomfort, and there's none present. I could also do a bulge test, which I can't do effectively because of trousers, or balloon test. And essentially I'm looking for signs of fusion. Any great amount of swelling is fairly obvious when you do those things. That completes my musculoskeletal assessment. I'm now going to finish with my neuro assessment. I'll complete my neuro assessment. Okay. So just again, this is soft and this is sharp. Okay. Yeah. So just tell me what you can feel on both sides. Eyes closed.
Soft. Sharp.
Okay. And then we carry on down all the way down the arms and legs and feet. And that's check-in sensation. I'm going to continue with tuning fork for vibrations. So you're going to feel the tuning fork. I just want you to tell me if you can feel vibrations.
Yeah.
Okay, so I'll do that bilaterally, and again with toes.
Yeah.
Okay, very good. So I've checked sensation. I'm going to check for the cerebellum coordination. Can you just put your hands on your lap like that and just rapidly turn your hands over back and forth? Okay, very good, and relax. Okay, so can you get your finger to touch my finger? Back to your nose, finger, nose, great. So last one, going to slide your heel down your shin. Okay, great. And again, I would test both of these bilaterally. So its coordination is good. I'm going to check for upper motor neuron lesions now. So I'm going to look at the Babinski test to start with. So I'm just going to, you're going to feel something sharp up your foot. Okay. Okay. Try that again. Okay. So an abnormal reaction would be that the toes are spread out and that we're not seeing that reaction. So we suggest that's abnormal Babinski. And I check for tendon reflexes. Just relax. Okay. So there's a normal reflex of his biceps. I'd also do triceps, pronator, patella, and Achilles. That completes my upper motor neuron test. And now, if you don't mind standing up for me. Okay. Oh, great. So I'm just going to assess his gait and balance now. Can you just walk over towards the camera and just do it nice and slowly for me? So I'm looking at his walking, and he's got normal gait, just stop there. So he's had a good heel strike and toe off. And this time I want to look at your tandem walking, so one foot in front of the other. Excellent, he's got good balance, just stop there. Put your feet together. Okay, bring your hands up like that, eyes closed. Okay, so assess his balance for 30 seconds, and then I'm just going to test. Okay, and he's got good balance, that's a Romberg's test. Okay, you can take a seat. Just give myself a minute, but I think that is me finished my assessment.
Okay, lovely, well done. If you take 2 minutes outside, I'll
Right.
call you back in for a couple of questions.
Okay.
Yeah.